Of course, I have the honor to share today in the Pacemaker basic course, and we will talk today about pacemaker programming and what are the options that we have in the pacemaker, and what are the programming parameters that can be done in patients with permanent pacemakers. Of course, we all know that basic pacemakers are either single chamber pacemaker with only one lead in the right ventricle, inserted in the right ventricle with only pacing lead in the right ventricle, or it is a pacemaker with dual chamber pacemaker, or two leads, one in the right atrium and the other in the right ventricle. Of course, we have another modality of three leads in the heart, with a third lead in the coronary sinus, which is the CRT, or the cardiac synchronization therapy. But I think this will be discussed later in later lectures. So we will deal today with patients having a single chamber pacemaker or dual chamber pacemakers, as we see in the illustration. Of course, programming is conducted with different programmers. Each programmer is with a certain type is dedicated for each type. Like, for example, Medtronic programmer for the Medtronic devices, the St. Jude or the Merlin for the Abbott devices or the St. Jude device. The Medtronic, this is the new or the more recent programmer for Medtronic, and of course different programmers for different companies are there. If we talk about programming, we have certain goals, or what are the goals that we need to achieve for programming. We do programming for the following goals. First, we should ensure that this pacemaker is functioning optimally, that it is utilizing the full capabilities of the device, and this is targeting improving the patient's well-being. Also, programming is needed to detect and diagnose any abnormality that arises in the pacing system. If we have a problem in pacing, if we have a problem in the sensing or the functions of the pacemaker, very important that programming is very important to detect any abnormality or any dysfunction in the function of the pacemaker. Also, we have a goal to improve the longevity of the device by appropriate programming, and we will see how to program the pacemaker in a way that we, as much as possible, to improve the longevity of the pacemaker. When the pacemaker starts to reach the end of life, or the elective replacement time at which the battery is depleted or not depleted, so it is very important to detect this time or this situation to replace the battery before it is totally reaching the end of life, and before the patient has a dysfunction or problem in his pacemaker. And finally, to manage all the situations that can arise for the patient or the patient can have during his lifetime, which may interfere with the function of this pacemaker. So we have many goals for programming. It is not just for measuring the parameters, measuring the pacing threshold only, measuring the longevity only. We have many goals for programming to achieve better performance of the pacemaker. The main or the very basic functions of programming include measuring the battery voltage and the lead impedance, the pacing threshold, the sensing threshold. These four items are the basic or the cornerstones of the programming. We may consider that the battery and the lead may be representing the hardware of the pacemaker, because the pacemaker as a hardware is consisting of a battery and leads. So we measure the battery voltage and we measure the lead impedance, which is the hardware function. And measure the pacing threshold and the sensing threshold, or the pacing and the sensing functions, which are the software of the pacemaker or the function of the pacemaker. We will start with the battery voltage. Of course, battery voltage is very important to estimate the remaining longevity of the pacemaker. All the pacemakers gives the longevity, how much is left in the battery life. It can give it by years, can give it also by years and months, and many devices estimate the remaining longevity based on the percentage of the pacing, how much is the pacemaker working or continuously pacing. Of course, if a patient is totally dependent on the pacemaker and he is ventricularly paced all the time, this will lead to more consumption of the battery and decreasing the longevity. The lead impedance affects the longevity of the battery, and of course the pacing outputs. If I need a high pacing output, this will increase more the consumption of the battery and decrease the longevity. We have some alarming signs regarding the battery voltage. The first is the ERI, which stands for elective replacement indicator. This means when I read on the programming or programmer that there is an ERI alarm, this means that yes, the battery is still working, but it is about to deplete. So this is an alarming sign for me that this patient will need battery exchange before affecting the function of the pacemaker. The pacemaker is still working, but it is about to deplete. Some models switch its mode to the simplest form, meaning that sometimes the patient is having a dual chamber pacemaker with a DDD function, but when the battery voltage decreases to a critical level, it switches to the simplest mode of pacing, which is the VVI mode, in an attempt to keep the pacing function till the battery exchange is done. So to decrease the battery consumption, the mode can be switched automatically by the device to VVI, or the simplest mode of pacing, till the battery exchange, in an attempt to try to increase the longevity of the battery. On the other hand, the term EOL, end of life, means that the battery is no longer working and there is no pacing from the device, and it is completely non-functioning. This is an example of the programming screen that appears in Medtronic, and we here see the longevity shown, which is 7 to 10.5 years, and some programmers show the voltage, and we can see it also. We can extract the voltage value from the data in the programmer. Different models have different voltages, but we can see this remaining longevity, which is very much comfortable for us, which is 7 to 10 years in this example. This is an example of the voltage, but it is a bit unclear, which is here 2.7 volts, and this is the screen of St. Jude or Abbott devices, in which the remaining longevity is displayed in this area. We move to the lead impedance, which is the second hardware that we measure for the pacemaker. And if we physically define the lead impedance, if we talk a bit physics, it is the resistance of the electric current through the lead or through the wire. This is physics. So it is considered the resistance of the electrical current across the lead, and any abnormality in the lead impedance is reflected or is a warning for us that there is a problem in the lead, whether there is an insulation failure or a lead conductor fracture. Also at the site or at the time of implantation, if I just implanted the lead and it gave me an abnormal lead impedance, so this means that there is a loose set screw, which means that I did not tightly implant or tightly set the screw between the lead and the battery at the time of implantation. So this is an alarming sign, and I should revise this matter during implantation before closing the sutures. Normally, in the normal leads of the pacing leads, the impedance ranges between 300 and 1000 ohm. And ohm is the unit of measuring the resistance of electric current. So it is in ohm unit. Some other leads, which are the shock leads, we measure another type of impedance in the high voltage leads, and it has other values. But regarding the leads that are for pacing and sensing functions, the normal values range about between 300 to 1000 ohms. If we find that there is a very low impedance, which is less than 250 ohms, so this may raise the suspicion that we have an insulation defect, which means that the layer of insulation that is surrounding the coils of the lead, there is a defect in this insulation layer, and this means that the leakage of the electricity can occur through this insulation defect, which will cause decrease in the impedance. So if I measure the lead impedance, I find that there is a very low impedance, this can mean that I have an insulation defect and I have a break in the insulation that is surrounding the lead. On the other hand, if I find the lead impedance very high or more than 1000 ohm, like sometimes it is more than 2000 or more than 3000 ohms, this can mean that I have lead fracture. And by lead fracture, we mean that there is incontinuity of the coils of the lead inside the lead, within the lead, without breaking this insulation layer. There is discontinuity of the coils that transmit the electrical current inside the lead. And of course, if we find this lead fracture, this lead will need for sure that it will be replaced with another true intact lead. So lead impedance is a very important measure to detect any abnormality, whether there is an insulation defect or a lead fracture. So we will move to the functions of the pacemaker. And we know that the functions of the pacemaker is either pacing or sensing. So we will detect the function of the pacing and detect the function of the sensing. And of course, any pacemaker is required to do both effectively with no problems. We will start with the pacing, which is the main function of the pacemaker. And when we define or speak about the pacing values, we should speak in two terms. The first term is the amount or amplitude or the value of the voltage that I give, which is the amount of the electricity that I give. And the other parameter is the pulse duration or the pulse width in which the impulse is given. So I give a certain amount of electricity in a certain amount of time. So I always say that the pacing value is, for example, 5 volts at 2.5 milliseconds, for example. So I can't say that I am giving a pacing of 5 volts and I stop. No, I should specify that this voltage is in a pulse duration or a pulse width of, for example, 0.5 milliseconds. The pacing threshold, as we said, is expressed in terms of voltage and pulse duration. When we measure the pacing threshold, by definition, the pacing threshold is defined as the smallest output voltage or shortest pulse duration required to initiate a depolarization wavefront. Any pacing spike or any pacing that I give to the ventricle is expected to initiate a wave of depolarization. And this wave of depolarization is translated into a QRS complex that follows the pacemaker spike, or the intrinsic wave or the V wave that is appearing after the pacing spike. If I do a pacing spike and it is not followed by a wave of depolarization, this means that this pacing did not capture. So if I have a pacing spike followed by a wave of depolarization, or a V wave, or a QRS complex at the surface ECG, so this pacing is capturing. But if I don't have this wave of depolarization, so I have failure of capture. Actually, the pacing threshold varies according to the site, the time of implantation, because in the first 2 to 4 weeks after implantation, there is some inflammation around the tip of the lead. There is some edema at the site of the lead insertion, and this can increase the pacing threshold for a certain time. This increase in the pacing threshold gradually resolves, and after the inflammation and the edema resolves, there is some fibrosis. There is a very small area of fibrosis that occur or formed around the lead, and the threshold starts to decrease. The presence of steroid-eluting leads, of course, can reduce the amount of inflammation and fibrosis, and can minimize these changes in the pacing threshold. So, as a definition, once again, the pacing threshold, of course, it is probably the most important aspect of programming, and it is defined as the minimum output at which the myocardium is consistently captured outside of its refractory period. The goal of measuring the pacing threshold and adjusting the pacing output, they are actually two goals that are completing each other. The first is to ensure that I am always capturing the ventricle or the chambers that I am pacing, that I am always reliably capturing. There is no malcapture. I am always, the pacing is translated into capture. And at the same time, the programming of the pacing threshold can be beneficial for me to maximize the pulse generator longevity to extent that it is consistent with the first goal. So I can decrease the consumption of the battery by adjusting the pacing output at a certain value that is that can enable for me the preserving the battery more, but at the same time with ensuring reliable capture. How do I do the pacing threshold? I start first with a pacing amplitude which is relatively high. Usually I give this pacing amplitude on a stable or constant pulse duration. For example, I can start with 3.5 or 3 volts at 0.5 milliseconds, and then I start to decrease the output of the pacing and continuously monitoring the capture of the pacing. Decreasing the amplitude, pacing. As long as I decrease the amplitude, it is pacing, until I decrease the amplitude and I have no pacing. So I can here see a pacing spike followed by a paced QRS complex. This is the wave that denotes that there is a capture, pacing, QRS complex, pacing, QRS complex. And then when I decrease the output till a certain value, I find that the pacing spike is not followed by a QRS complex. So this means that there is a failure of capture in this impulse, and the threshold is the smallest or the lowest value of pacing that caused the capture. So the pacing threshold is the minimum value of pacing, or the minimum voltage of pacing that caused capture and caused a wave of depolarization. This is another example of how to measure the pacing threshold. Of course, when I or I test the pacing threshold, first I should tell the patient what I is going to do, because he can feel some palpitation. Usually, some physicians start to program the patient or test at a higher rate to ensure that it is dominating over his intrinsic rhythm. So sometimes the patient can feel palpitation, and it may be uh, 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 bothering for the patient. So I should inform the patient and explain what is the procedure that I will do. I will tell him that you will feel now some rapid rates. Don't be worried. Don't be anxious. I am doing this procedure. I am doing this high rate. Don't be worried. Then I will start the forced pacing and periodically lower the test value, which is the amplitude. And as we see here in this electrogram or in the EGM, that when I reached 1.25 volts, there is spike and QRS complex, spike QRS complex, spike QRS complex, spike QRS complex. So 1.25 is capturing, and it is with persistent capture. And when I decrease to 1 volt, here, as we see here, this is capturing. And when I decrease to 1, here there is the pacing, or there is non-capture here at the value of 1 volt. So this means that 1 volt is not persistently capturing. So the pacing threshold of this patient is 1.2 volts. Of course, I should say 1.25 volts at 0.5 millisecond or whatever the pulse duration that I'm working on. So the threshold in this example is 1.25 volts, and this pacing threshold will be the reference for me in adjusting the pacing output at which the pacemaker will be programmed later on. An important point that sometimes the patient has some intrinsic rhythm. Sometimes the patient has intrinsic rhythm, for example, at a rate of 80 or 75 beats per minute. If I make the test or the pacing threshold test at a rate of 60 beats per minute, it will not capture, and the intrinsic rhythm will be the dominant rate, or the intrinsic rate. So it is very important that I test the pacing threshold at a higher rate other than the intrinsic rhythm, so that the pacing rate is apparent for me. Of course, when we do pacing, we should bear in mind that we have different types of polarity of pacing. We have the bipolar pacing, which is nearly the default or the standard of pacing. Of course, it is better than the unipolar pacing. But sometimes if we have some values that are high, or we have high pacing thresholds in the bipolar pacing, sometimes we measure the pacing threshold in the unipolar pacing and see what are the values and compare which is better as values between unipolar and bipolar. But of course, unipolar has many benefits of less interference and less electromagnetic interference and less consistency. Usually the bipolar is preferred by most of the physicians, nearly all, but unipolar pacing sometimes has values that are better. Okay, we had a value of a pacing threshold, for example, 1 volt, 1 volt at 0.5 milliseconds, for example. So based on the pacing threshold, we will decide what pacing output will the patient or what the pacemaker will be programmed at. Usually, we multiply the pacing threshold by the double, by 2, and we adjust the pacing threshold, so the pacing amplitude by double the pacing threshold. For example, the pacing threshold occurred to be 1.5 volts at 0.5 milliseconds or 0.4 milliseconds. So I adjust the pacing amplitude on 3 volts, double what the 1.5. But what about if the pacing threshold is less than 1? Do I routinely adjust it only just the double? Some physicians can increase just the double. Some other physicians can put a minimum of 2.5 volts. The 2.5 volts as a value, some consider it as the minimum output that can programmed. They don't like to decrease the output below 2.5 for safety reasons. Later in the later slides, we will see that there is an option of automatic pacing or automatic capture tests, which can decrease these outputs to less than 2.5. But this is the automatic capture. But as a physician that I am adjusting the output, many physicians keep the minimum output at 2.5 and does not decrease the output at 2.5, even if the threshold is less than 1 volts. Sometimes we give a safety margin that is more than double in some situations in which we are a bit worried about the patient. Like patients who are dependent on the pacemaker, who does not have any intrinsic rhythm. These patients are very sensitive, and these patients, I cannot narrow the safety margin. The safety margin is the value between, or the margin that is between the threshold and the pacing output that I'm adjusting for the patient. So if the patient is dependent with some risk that he will enter into baseline and does not have any intrinsic rhythm, so sometimes some electrophysiologists prefer to just increase the safety margin a bit to be more on the safe side. Also, the patients who are placed on medications that can change the pacing thresholds, and one of the most common is the amiodarone. It can alter the pacing thresholds and can change the pacing thresholds along the course of the patients. So these patients, I prefer to increase the safety margin a bit just to be on the safe side. Also, patients on dialysis or patients having metabolic abnormalities with wide swings in the electrolytes or metabolic status can have changeable pacing thresholds. So to be on the safe side, I can increase a bit the safety margin and adjust the pacing output at a higher level. We move on to the other function of the pacemaker, which is the sensing. And although I need from the pacemaker to pace well, I also need the pacemaker to sense also well. I need the pacemaker to truly sense any intrinsic activity that occurs in the heart, so as to avoid unneeded or inevitable pacing at the time in which there is an intrinsic activity. So sensing is very important, and it is very important, and the importance increases in case of the presence of intrinsic activity. How to measure the sensing? Also, I will tell the patient what I'm going to do, but at that time, or the sensing test, I will reduce the pacing rate to give the opportunity for the intrinsic event to occur. So I can adjust the pacing at about 30 or 35 beats per minute, because if we have an intrinsic rhythm, I can give the intrinsic rhythm the chance to occur and appear, so that the pacemaker can sense it, and I test the sensing of the device. And I start to increase the value of the sensing and observe the loss of inhibition when the pacemaker does not sense, and when it does not sense. So this means that this is a sensing threshold of the device. As long as it is sensing, it will not pace. So I will consider that this is the true sensing. And when the sensing does not occur and there is no sensing and there is starting of pacing, so this means that there is no sensing from the device and the value is the sensing threshold. This is an example of the atrial sensing test from an atrial lead. So when the value was at 2 millivolts, it was sensing. When sensing increased the value to 3 millivolts, it lost the sensing. So this means that the sensing value is at 2 millivolts. When I adjust the sensitivity on 2 millivolts, so this means that I am ordering the pacemaker to sense any wave that is less than 2 millivolts. So any wave that is more than 2 millivolts, it will not sense. So I adjust the sensing and the sensitivity of the pacemaker according to the sensitivity test that I find. This is an example of an R wave sensing, and this is the value at which the R wave was sensed. This is the R wave sensing from the ventricle, and this is the value of the R wave amplitude range. It is here measured between 13 to 14 millivolts. So this is very comfortable with me. This means that the lead in the ventricle has a good sensing function because it can sense up to 13 millivolts. And this means that the sensing function of the lead is good. And any wave or any waveform in the ventricle can be sensed properly. The sensitivity is very important to avoid these two problems. When we set a sensitivity of a 2.5 millivolt, so this means that any wave above the 2.5 will be sensed, but this can cause a problem of oversensing because sometimes the T wave amplitude is higher than this 2.5 millivolts, and it can be sensed also in addition to the sensing of the QRS complex. So this means that there will be double counting, and this is a problem, and it can cause oversensing, and this can lead to abnormal functions. For example, the automatic mode switch, because abnormal heart rates detection. If this is an atrial lead, it can incorrectly diagnose atrial arrhythmia and can cause automatic mode switch. On the contrary, if the sensitivity value is very high, up to the level that sometimes the QRS complex is sensed when it is more than 4 millivolts, and sometimes it is not sensed when it is less than the sensitivity value. So this means that this sensitivity value will not ensure consistent, reliable sensing. So if I adjust the sensitivity too low, so the atrial lead, the lead will sense many events that are unneeded. And if I set the sensitivity at a very high value in relation to the measured R wave, so sometimes there will be undersensing, and sometimes there will be an intrinsic rhythm that the pacemaker will not sense, and this will cause unneeded pacing at this situation. So measuring the sensing and adjusting the sensitivity value according to the sensing test is very important. I should not set the sensitivity at a very low values, and also I should not test it at a very high values. These are the cornerstones or the basic parameters that I test in the programming, but also there are many pacemaker options, pacemaker programming options, like lower rate interval. And of course, lower rate interval determines the minimum rate at which the chambers are paced. And adjusting the lower rate limit or lower rate interval is determined according to the pacing indication and the presence of intermittent or constant bradycardia or even the heart block. And of course, I will adjust it at the rate that is physiologically suitable for the patient, according to his symptoms, according to his state. Of course, if I have the possibility of minimizing pacing as much as possible, I will do, but at least this is the lower rate interval that the pacemaker will not pace at a rate below this rate. And of course, when I adjust the lower rate interval, it is actually translated inside the pacemaker as the interval between the paced or sensed ventricular event and the event that is followed this, with the lower rate interval set in milliseconds as the longest interval permitted between a ventricular or sensed ventricular event and the succeeding ventricular event. So this is the lower rate interval. Of course, lower rate interval is in the single chamber pacemakers, and it is very important in single chamber pacemakers. Regarding the upper rate interval, it is not there in the single chamber pacemakers like AAI or VVI, and it is mainly in the dual chamber pacemakers. And in adjusting the upper rate interval, we can have two definitions or two parameters that are adjusted, which are the maximum tracking rate and the maximum sensing rate. The maximum tracking rate is the maximum rate that is permitted for a pacemaker or a dual chamber pacemaker to track the atrium or make the ventricle track the atrium. So it is the maximum rate that is permitted to track the atrium and to maintain a one-to-one conduction, meaning that I sense the atrium and follow by ventricular pacing. When the atrial rate is 100 beats per minute, so I will track it, there is no problem. 110, I will track it, no problem. But if the maximum tracking rate is 120, for example, so I can track I will not be able to track an atrium above the maximum tracking rate that I'm adjusting the patient on. So if I adjusted the maximum tracking rate on 120 beats per minute, and the atrial rate is more than this maximum tracking rate, so the atrium will not track, or the ventricle will not track the atrium. And the question is, what if the atrial rate exceeds the upper rate limit? If I have an intrinsic conduction, so the ventricular rate will exceed the upper rate limit and ventricular pacing will inhibit it, and it will be conducted to the ventricle, so I will have atrial sensing and ventricular pacing. But if the patient had no intrinsic conduction, so there will be no tracking, and either wing-back or 2-to-1 conduction will occur. So the atrium will not track the ventricle if the atrial rate increased or exceeded the upper rate limit. Another parameter that should be very important is the AV delay. And the AV delay is the normal PR interval, or the normal physiological PR interval, which is the interval between the atrial event, whether paced or sense, between the atrial event and the paced ventricular event. It is the normal PR interval or the physiological PR interval, and adjusting it is very important. First, to adjust the timing interval and the physiological timing intervals between the two chambers. And it is very important also in maintaining intrinsic ventricular activity if possible. If we have an intrinsic activity or intrinsic conduction, and there is a possibility of avoiding pacing, so one of the tools that I can use is the AV delay, because I can give a bit longer AV delay to permit the intrinsic conduction if there is possibility for that. So the AV delay is either following an atrial sensed event, and it is called a sensed AV delay, or a paced ventricular event, atrial event, so it is called paced AV delay. So we have a sensed AV delay or a paced AV delay, but at both values, they are the interval between the atrium and the ventricle, and it is the physiological PR interval. Usually the paced AV delay is adjusted between 120 to 200 milliseconds, which is the normal value of the PR interval. When we adjust the sensed AV delay, usually we adjust it at 20 or 30 milliseconds shorter than the paced AV delay, because when there is a sensed AV delay, so the impulse is arising from the SA node, and we have the atrial lead, for of course, in most of the situations in the right atrial appendage. So if there is some delay between the arise of the impulse from the SA node to reach to the atrial lead to sense it. So we do some compensation in lowering the sensed AV delay a bit, like 20 or 30 milliseconds. Recent pacemakers have dynamic AV delay, which allows shortening of the AV delay and increasing the AV delay at exercise and at rest. At exercise, the AV delay shortens automatically, and when the patient returns to rest, so the AV delay starts to be longer once again. This is very important. It's called the rate adaptive AV delay, and it is very important and gives more physiological functions. When do I tend or to increase the AV delay? Well, in a patient with a high grade AV block in which there is no AV conduction, there is no big deal in prolonging or shortening the AV delay, because it is in both situations the ventricle will be paced. But the value of a long AV delay is important in a patient with intrinsic AV conduction, because if I have a chance that the intrinsic conduction or the normal conduction can take its way to the ventricle and captures the ventricle, it is very beneficial for the patient. First, to avoid or minimize the ventricular pacing, not only to preserve the battery life, but also to avoid prolonged RV pacing, and for the ventricle to receive the impulse naturally through the normal conductive system better than RV pacing, to avoid the potential harm of prolonged RV pacing in some situations that can lead to development of myopathy or cardiomyopathy. So it is very important to prolong the AV delay as a trial to promote intrinsic conduction. But in some situations, I make sure that the AV delay is short. When do I tend or to adjust a short AV delay? Sometimes in Hookham patients with LVOT gradient, with a high LVOT gradient, sometimes the short AV delay can decrease the gradient a bit, but it is not does not have a very powerful or a great evidence. Okay. Of course, in patients with CRT that have implantation of CRT, I tend to decrease the AV delay even to up to 80 milliseconds to ensure 100% pacing. In CRT, I want to pace all the time. I want bi-V pacing all the time. I target 100% pacing. So I should give the pacing spike of the pacemaker before the intrinsic conduction. So I shorten the AV delay to be sure that I am the pacing, or I am taking the pacemaker takes the lead in the ventricle. Okay. Another option or another programming parameter is the rate adaptive parameter. And this is what is called the R in the VVIR or the DDR, which is the rate response. And these are options that can censor or monitor the activity and increase the lower rate limit or the upper rate limit according to the rate adaptive parameters. In patients with VVI, the pacing is. Excuse me, can we turn off the sounds for the colleagues that are talking? Programming the rate adaptive pacemaker can increase the rate in, for example, the VVI patients who have a stable rhythm, which is constant, lower rate limit at, for example, 60 or 70 beats per minute. If I have the option of VVIR, and all the single chamber pacemakers now have this R option, this can increase the heart rate according to the sensors or the moving sensors that are there, to increase the heart rate at exercise or at movement, and I can adjust the rate of rise of the heart rate and the rate of decline of the heart rate, and the percentage of increase and the maximum heart rate that can be adjusted. It is also there in dual chamber pacemakers, in which there is an atrial pacing. So the atrial pacing in atrially paced patients in having dual chamber pacemaker, the presence of the R option or the rate adaptive is important also to increase the heart rate in case of exercise or in case of activity. And this opens the second upper rate limit interval, which is the maximum rate or the maximum sensor rate, which is the second maximum rate in dual chamber pacemakers. We talked about the maximum tracking rate in which we track the atrium, but the maximum sensor rate is the maximum increase in the heart rate in response to specified sensors like the accelerometer or the ventilation sensors. The motion, either acceleration or vibration, the changes in the impedance like the minute ventilation, the duration of QT interval, some sensors that provide that the patient is having an exercise or having motion, so it increases the heart rate according to this activity, and this is called the maximum sensor rate. This is an example of a patient with a single chamber pacemaker with an adjusted lower rate limit at a certain interval, but the presence of the rate response, the presence of the R in the VVI to be the VVIR, that there is a response to the activity to decrease this heart rate, to increase the heart rate according to the activity. And this is an example of a sensor rate controls in a patient with a dual chamber pacemaker. This is the lower rate that is permitted, and the lower rate that the pacemaker should not decrease below this rate, which is adjusted here for 60 beats per minute. And when the patient performs exercise or makes activity, this sensor-driven pacing increases the atrial pacing rate up to 110 beats, and this is adjustable. I can adjust the sensor rate or the maximum sensor rate at the rate that I need according to the patient needs and according to the patient situation, not to increase the heart rate, for example, in patients who are ischemic or we don't need very high rates. So all these values are adjustable in our hands. Another important programmable option is the mode switch. Mode switch, of course, is in the dual chamber pacemakers or the pacemakers that can sense the atrium. Mode switch is the ability of the pacemaker to change the mode from a tracking mode or P-wave synchronous tracking mode to a non-tracking mode. And this is very beneficial in case of inappropriately rapid atrial rhythm, like occurrence of atrial arrhythmia, atrial tachycardia, atrial fibrillation, because we are depending on the tracking function of the pacemaker to sense the atrium and pace the ventricle, to sense the atrium and pace the ventricle. This is in case of sinus rhythm. But if we develop an atrial arrhythmia, so it is not needed to track this high, very high atrial rate. So the pacemaker switches its mode from a tracking mode to a non-tracking mode, which means that it can switch to, for example, a VVI to avoid these rapid atrial rates. So the pacemaker switches to VVI, and there is a continuous monitoring of this atrial activity during the VVI pacing. And when the atrial arrhythmia is terminated, so the device can switch back to dual chamber pacing with normal tracking when the atrial tachycardia stops. So this automatic mode switch causes the pacemaker to switch its mode from a tracking mode to a non-tracking mode in case of atrial arrhythmia. And when the atrial arrhythmia is over, it returns back to the tracking mode or the DDT mode. This is very important in patients who have frequent atrial arrhythmias like atrial tachycardia or atrial fibrillation. Hysteresis. Also, hysteresis is a very important option or programmable parameter in the pacemaker because it allows the rate to drop below the programmed pacing lower rate interval to promote any intrinsic activity that can occur and promote this intrinsic pacing. Sorry, this intrinsic activity or this intrinsic beats. So if the heart rate, for example, is adjusted on a pacemaker at a 70 beats per minute, which means that the pacemaker or the lower rate limit inside the pacemaker will be adjusted at this value in milliseconds. So I can adjust a hysteresis rate of 50 beats per minute. So the pacemaker will allow the ventricular rate to fall to 50 beats per minute before pacing, or if there is any intrinsic activity more than 50 beats per minute, so the pacemaker will not pace and will give the opportunity to the intrinsic activity to occur. If I don't have an intrinsic activity more than these 50 beats per minute, so the VVI will pace on the 70 beats per minute. So I will give a chance for the intrinsic activity to occur. If I don't have any intrinsic activity more than 50 beats per minute, so the pacemaker will pace on this 70 beats per minute. Hysteresis, of course, prolongs the battery life and prevents unnecessary pacing. And of course, increases the potential for maintaining the patient's intrinsic rhythm. And also in VVI mode, it can help maintain EV synchrony whenever possible and reduce likelihood of retrograde ventricular conduction. Another option is the rate drop response, and it is a feature in some dual chamber pacemakers that are needed in patients with neurocardiogenic syncope of the cardioinhibitory type. We all know that the neurocardiogenic syncope is either of the vasodepressor or the cardioinhibitory response, and the patients with cardioinhibitory response that have certain criteria can have a pacemaker, but it is very important that this pacemaker have this rate drop response in which pacing at rapid rates is important because these patients have sudden fall in their heart rates. The heart rate suddenly increases up to asystole. So these patients have they need a rapid pacing response that is present in pacemakers that have this option of the rate response. Sleep rates, which is an option in many devices, can give the opportunity to adjust two rates for the patient, especially if we have a lower rate limit of, or in a single chamber pacemaker in which there is a lower rate limit, for example, adjusted at 70 beats per minute. I can have the opportunity that I adjust another rate for sleep or during the sleep hours to be more beneficial or more physiological, especially in sensitive patients who have this heartbeat awareness, because sometimes they are bothered with even the 70 beats per minute could be bothering for him. So this patient needs during sleep even a lower heart rate. So for example, this option that I adjust the basic rate, for example, at 60 beats per minute and adjust the night rate at 50 beats per minute at a lower rate, which is more physiological during sleep. And also I have the option to adjust when does this night rate starts, for example, from 10 p.m. till 6 a.m. the next day. So every time at 10 p.m., the basic rate or the lower rate limit will be decreased to 50 beats per minute. Also, we have the automatic capture control that I mentioned earlier. The automatic capture control is a function that is conducted by the device or by the pacemaker. There is regular assessment of the pacing threshold at a regular interval that is adjusted by the programmer, and I can adjust the pacing threshold according, and the pacemaker itself will adjust the pacing amplitude according to the automatic capture control results that it occurs. Once the pacemaker sees a loss of capture, or once the pacemaker sees or detects a high threshold in the pacing test, so it will immediately increase the output on itself. And then when the monitor for capture decreases or it finds a less capture threshold, so it will adjust it according to the situation. So this is very important in patients who have variable or unstable threshold tests, and it can also increase in or help in conserving the battery life by reducing unnecessary high pacing outputs, because it is unlogical that I maintain the pacing output at high levels because of, for example, that the patient does not come for a visit or does not follow up the visits, the pacemaker programming visits, and we need to decrease the output, and there is no need for this high output. But if we have an automatic capture control adjusted for the patient, so it can regularly check the capture threshold and adjust the amplitude accordingly. Also, this can be applied to the sensing, because sensing also can be measured by the automatic sensing test and adjust the sensitivity accordingly, either by increasing the sensitivity or decreasing the sensitivity. The last thing are the stored information. There are many information that we can get from the pacemaker, like how much is the percentage of the pacing, whether the atrial or ventricle, how much is the percentage of sensing, what are the rates that the ventricle or the atrium was paced on, which are the rate histograms, the average ventricular rate, whether the patient developed atrial arrhythmia like AF burden, what are the timings, what are the duration, what are the rates, what are the frequency of episodes. All these data can be achieved from the programming. We can detect also if the patient developed any ventricular high rate episodes, any mood switch or automatic mood switch events, and gives us how many minutes or how many hours had the patient atrial arrhythmia. and the rate of this arrhythmia. It also gives us important data about the patient activity, whether the patient had adequate activity, had adequate exercise, or the patient was inactive. Also gives us important curves about the variability of the heart. This is an example of an atrial histogram in which most of the atrial rates were at the 60 beats per minute or more, with few episodes with a rate less than the lower rate interval, and some atrial episodes that may indicate that there are some atrial arrhythmias if the rate is more than the exceeded rate. This is an example of a stored EGM in which the patient had atrial arrhythmia, and we can see here the atrial activity that is sensed. And of course, this patient had this mode switch to a non-tracking mode. And these are the parameters, or example of the parameter adjustment in this patient. And we can see here the mode at which the mode switch occurs, which is 175 beats per minute. This is the lower tracking rate. This is the upper tracking rate. This is the upper sensor rate. Here is the amplitude, whether the atrial lead or the ventricular lead, the amplitude, the pulse width, and we can see here that there is an amplitude of 1.5 volts at a 0.4 milliseconds, which is due to the automatic capture control. This means that the automatic capture control is the one who adjusted this 1.5 volts. This is the value of the sensitivity of the atrial lead, which is 0.5 millivolts. This means that any wave above this 0.5 millivolt will be sensed by the atrium, but any wave less than 0.5 millivolts will not be sensed by the atrial lead. The pacing polarity means that I will pace in the bipolar mode, not the unipolar, and the sensing polarity also, it is a bipolar mode, and this also applies in the ventricular lead. This is the value of the AV delay, and we see here that the paced AV delay is set on 150 milliseconds, and sensed AV delay a bit shorter at 120 milliseconds. Okay. The last thing to mention is how frequent does the follow-up visits or the programming needed for patients with pacemaker. Actually, we should make programming for the pacemaker on the day of implantation. And it is advisable that also we can do another set of programming before discharge of the patient. And we ask the patient after implantation to return 6 weeks after implantation to make his first follow-up visit, because it is expected that at the duration of the 6 weeks, the pacing threshold values increase, as we said, because of the inflammation and the edema, and then it returns back after the end or at the end of the 6-week duration. So at the 6-week implantation time, we can decrease the pacing thresholds according to the values we find at the testing. Then if everything is stable and all the parameters are accepted, then we will ask the patient to return after 3 months, and then the evaluation will be performed 6 months or twice per year for dual chamber pacemakers. Regarding single chamber pacemakers, some electrophysiologists may see that twice per year is not much needed, and can just program the patient only once per year for the follow-up for pacemakers that are single chamber. But actually, we routinely make twice per year. This means that every 6 months we do a pacemaker programming, whether a single pacemaker or a dual chamber pacemaker. Thank you very much.